start with this topic today, as Poonam has said, the hot topic, but I do not know how much of air I can clear and how many problems or queries I may be able to solve. But anyway, let me try. So anyway, what has happened is, ever since this ART Act has come into existence, ever since we've seen it, there has been a total chaos in our lives, especially those who have been practicing infertility and ART, and we really do not know which way to go and what to do. So that is what has happened. Rather than clearing things for us, it has caused much more confusion. So let us try and think what there is in this act for us. For us who are offering advanced infertility treatment in our clinics, and for every doctor who is seeing an infertility patient and has the potential of referring patients to an IVF center. What is there that has been created, which was not there earlier, and what is in it that is going to make a difference to us? So the aim is therefore to identify the strengths of this act and then turn them in your favor. So that is what we should try to do now. Instead of finding faults and trying to figure out what we are going to do, let us try and see what are the strengths over here, and then let us see how we can make use of them and make this into a really, really useful act for us. So let us consider let's do a SWOT analysis. Let's see what are the strengths, what are the weaknesses, what are the opportunities that we have, and what are the threats that we have. So as far as strengths are concerned, this act has been made to regulate the ART scene in India, and it is meant to weed out the illegal players, to stop unscientific and antisocial practices, and in order to have a better governance. What are the weaknesses? It has a lot of ambiguities, as we all know, and the implementation of the act is not proper. We are finding that there is a lot of struggle in implementing this across the country, and that is what is causing a problem. And of course, the act is not very friendly to the patient or to the doctor. What are the opportunities that we see in this act? We actually can have a consolidation of practices, more numbers to treat, an opportunity for research and scientific advancement. What are the threats? We are required to do strict data management that may go wrong, severe punishment on minuscule offenses, third-party reproduction may go awry, and unavailable to those who actually need this kind of treatment. So those are the threats that we have out of this. And of course, there is a lot of opportunity which we will have to tap somehow and try and work all this to our favor. So what are the salient features of this ART Act then? Number one, it classifies the entities that are working under the Act. We have been classified into ART clinics, ART banks, and surrogacy clinics, which has been separated from ART as such. Number two, there is a mandatory registration of all with a fees, not only for registration, but also for renewal. There is a difference in that. There is a renewal fees as well. Again, there is a mandatory staff in each with specific qualifications. And of course, there are defined functions and permissions for the enactment of the procedures. And this also is followed by severe punishments if you don't actually follow the Act. So this is how it is now being structured. Classification, mandatory registration, mandatory staff, defined functions, and of course, serious punishments. So this is the website which you all must be familiar with. You all should know this. If in case you don't, please note down that this is the website where everything is uploaded every day, whether it is the boards and authorities or whether it is the notifications or any appeals that people have made about this act. And this keeps on scrolling over here, so you can download any of the notifications that we are getting. All of it is found on this website. So what is the process then of registration? If registration is mandatory, what is the process? Notification of the Act was in January 22, and then it was to be followed by notification of the national and state boards, then the rules and regulations after the amendments, if any, notification of the registries and the boards, and finally registration had to be applied with a payment within 60 days of the portal after announcement of the state authority. So this is where we come in, that we have to register within 60 days of the announcement of our own registry and the board of that particular state, so that everything keeps on happening in order. And once this registration fees has been paid, and once the registration has been, the form has been uploaded onto the portal, then what happens is within 1 month, they are supposed to actually start the process of registration. The inspection has to begin, and they have to finish everything within 90 days. So that is what it is. And it is also written over there that if it is not, just as it is in the PCPNDT Act, that if you don't hear from them, then you can deem yourself as registered unless proved otherwise. And of course, yes, we know practically these things are different. We know that we do need to have to wait for the particular circular, otherwise we may get into problems. So that is what I meant when we are saying that implementation is not as good as is written in the whole act. And of course, we all know that there is a fees for every level of clinic that has been formed over here, whether it is the bank or clinic or it is surrogacy clinic. We'll come to it a little later. And here are the lists of the boards and registries that have been formed across the country. And you can see over here that Delhi as a state is actually lagging behind. We neither have a board nor we have a registry. So therefore, these states are much far ahead of us. And in many of the states like in Bengal, the West Bengal State Board and the authority has been formed and the registration and everything has taken place. So some of the states are much ahead of us, whereas others are lagging behind. Now, what is the difference between the ICMR guidelines of 2005 and this particular act? Even over there was the formation of boards and national registry. It was mentioned over there, but it never happened. We never saw any registry being formed, although it was kind of initiated towards the end of it. You know, we started getting registration. We were asked to register with ICMR, but then nothing more happened beyond that. And then, more importantly, what was happening was that the ART clinics were divided into 3 levels. The primary level, where diagnostics and basic treatment was allowed. Secondary level, level 2 clinics, where diagnostic treatments and up to IUI husband and IUI donor was allowed. And then the tertiary level 3 clinics, where all facilities for IVF and related procedures were to be done. There were no ART banks and no surrogacy clinics. So all of this was done entirely in the level 3 clinics and nothing was different. And of course, if you wanted to do an IUI, it was in level 2 clinics. So that was that is what was happening over there. And now what happened in 2022, we had the formation of the National ART and Surrogacy Board, the state boards, the surrogacy boards, and the registration authority. And of course, we know now that we are in nearly in end of October, and we know that many of these boards and authorities, as I stated earlier, have already been formed. So yes, we are seriously moving ahead in this respect. And then more than that, the ART clinics have been now divided into level 1 and level 2 instead of the 3. We have level 1 and level 2. And then we have an entity called the ART banks, and we have the surrogacy clinics. So these are the various entities that are now existing as against those in 2005, and we shall be describing each one of them. So what are the ART banks? Just let us finish this first, because basically this doesn't concern much of us. These are responsible for the screening, collection, and registration of the semen donor and cryopreservation of the sperms. Kindly note that it is meant to handle everything related to the sperms. Collection, registration, and cryopreservation, everything, screening. And on the other hand, for the oocyte donor, it is only to perform the screening and registration of the oocyte donor. Oocyte collection and storage is not going to happen in the banks, it will happen in the clinics. So therefore, there is a difference. While the sperm is entirely being handled by the ART bank, the oocyte is partly being handled by the ART bank and partly by the clinic, where the oocyte collection is going to take place, and extra oocytes from the same donor would be stored in that particular bank, in that particular clinic. So, however, a bank can operate both as a semen bank or an oocyte bank, and or they may have both. Most importantly, they have to maintain the records or data of all the donors, and this shall regularly be updated in the national registry as provided in sections so and so of Act 4. So any of these banks are at the moment non-existent, but like I said, Madhya Pradesh is ahead of us, so they have the formation of banks over there. And then they have also started to have banks in Calcutta, in West Bengal. So wherever there are registries, you will find that the banks have come up, and they have also been registered in those states. However, this is not what is happening in Delhi, and we are in a dismal state at the moment. Now, coming to the other entity which is new, that is the surrogacy clinic. Now, we all know what a surrogacy treatment is, and therefore anything pertaining to surrogacy is going to be handled by this specialized clinic which is registered as a surrogacy clinic. If you do not have a registration of a surrogacy clinic, you cannot entertain this type of treatment in your center. So this is basically within a period of 60 days from the appointment of the appropriate authority, they also have to apply for registration, and then the license has to be renewed every 3 years, as against the license of the ART clinics, which is renewable every 5 years. Here, the license will have to be renewed every 3 years, and all the documents and charts, mind you, have to be kept for a period of 25 years, as against 10 years of the ART clinics. So this is a huge time. I think it's the lifetime of a gynecologist. When you start practice and you end practice, you will be keeping all your records safe and sound so that nothing goes wrong. So this is a separate entity completely, which is basically going to be responsible for anything to do with surrogacy. Now, defining the two clinics which is most important for all of us as gynecologists, what are these level 1 and level 2 clinics? The level 1 clinic is basically for the diagnosis of infertility, the cause, and only up to IUI. The level 2 clinic, on the other hand, is carrying out all the advanced investigations and treatment, and such clinics are also allowed to undertake research. The level 1 clinic is to be registered with a payment of 50,000, and level 2 clinic a payment of 2 lakhs. And this registration, like I said, has to be renewed every 5 years. Surrogacy clinic, on the other hand, is also to be registered by a payment of 2 lakhs, and registration is renewed every 3 years. So that is the difference between the two. And monthly report of the data has to be sent to the appropriate authority and board every month for all of these entities. Now, very importantly, level 2 is what we are interested in as IVF people, where the procedures and case and techniques can be done. So you're allowed to actually do everything in these clinics, whether it is surgical retrieval of gametes, whether it is handling of oocytes, using the sperms for fertilization, transfer of the embryo, carrying out storage, etc. And basically they can be provided, they can also undertake research. However, shifting of gametes is allowed only with the permission of the national board, and that also shifting your own gametes. Shifting the gametes of a relative, shifting a gamete of somebody who knows you is not allowed, even if that person is willing to give you donate the gametes to you or donate the embryos to you for use. You still cannot transfer them from one clinic to another, even if you have a permission. Again, the posthumous storage of gametes is allowed after prior consent of the dying patient and the permission of the board. Gametes and embryos may be destroyed on non-payment of renewal fees, and if patient does not respond beyond 2 reminders, you are allowed to destroy the gametes. This is something new which was not there in the ART Act earlier. So therefore, this is a little bit of a respite, because we have so many unclaimed gametes and unclaimed embryos lying with each one of us in our clinics. As far as the mandatory staff is concerned, level 1 clinic, the requirement is that of a gynecologist with a post-graduation in gynae and a counselor, which was excluded in the June notification, where this entity was excluded. However, it is important and it is very interesting to note that there is no mention of either an embryologist or a technician in a level 1 clinic. There is no andrologist also who is going to carry out all the semen, is going to handle the semen in level 1. So probably what they are expecting from the gynecologist is that she should be actually doing her own semen analysis, the semen preparation also, before doing an IUI, because basically you are not now allowed to get any semen from any other clinic, because that is also not allowed. You cannot move gametes from one clinic to another. So how are you going to get a sample from a path lab or a pathology clinic? You need to now undertake the sample preparation, etc. in your own clinic. So that is something which is very, very important and which we also need to understand. In the ART clinic, staffing of the second level 2 clinic is of course much more, where there is, in addition to a gynecologist and anesthetist, one embryologist and one counselor, and the additional staff at the level of director and andrologist may be employed by the ART level 2 clinics. The only difference is that in the level 2 clinics, a gynecologist, in the act, when it was brought out in 2022, the definition of gynecologist was the same as meaning as it is assigned in the Preconception Prenatal Diagnostic Technique Act, which means that the PCPNDT, as it describes the gynecologist, the same was applicable in this act as well. However, when the rules came out in March 22, and then there was another revision in June 22, that they actually changed this definition of a gynecologist, subdividing it into gynecologist for level 1 and level 2. Now here, in level 2, the gynecologist has to be a medical postgraduate in gynae and obstetrics and should have a record of performing 50 oocyte retrievals under supervision of a trained ART specialist. Records of procedures need to be maintained, or with 3 years of training in a registered center, or with super specialist DM or fellowship in reproductive medicine, or experience of not less than 3 years in reproductive medicine. So basically, any of these would make a person eligible to conduct IVF and practice ART as a super specialty. Otherwise, a plain gynecologist who does not have this kind of a training, who has no certification of this kind, would not be allowed to carry out IVF in the coming times. So what are the ambiguities then in this classification and in this act? It is not clear whether the general gynecologists are allowed to stimulate the patients for IVF even. We do not know whether they can stimulate the patients and send them to IVF centers. It is not clear whether the general gynecologists can be affiliated to level 2 clinics through formal registration in order to perform IUI and refer patients for IVF. This is also not mentioned. However, as I speak, about a week ago or 10 days ago, the IFS, Dr. K.D. Nair, did inform us that he has received a letter because they had put in a query to the directorate, and they have received a letter saying that yes, they can be affiliated to the level 2 clinics by sending their names, by adding their names, as we do in a PCPNDT department. You add the names of the people who are going to come and do scans in your clinic, or who are going to do ultrasounds and ovum pickups in your clinic, and they get affiliated. Similarly, the general gynecologists can be affiliated to the level 2 clinics in a similar manner. They just have to be registered with the level 2 clinics. Now, embryologist is another big query. You can see here this whole huge slide, which tells you the various combinations in which you can have an embryologist with you. However, what is important is that now they are saying that whenever you are employing an embryologist, he has to be fully qualified and a postgraduate of some kind, with some kind of a clinical embryology training, with some kind of an embryology training in humans. So therefore, as we were employing graduates in life sciences or biotechnology and reproductive biology in the past, now it is clarified that they would have to have at least 5 years of experience of working in a registered ART or IVF clinic, and they should have performed at least 500 IVF lab procedures, including ICSI, and at least 100 cycles of cryopreservation of embryos. So if you have somebody who has not done this who does not have this kind of experience, then he or she is cannot be employed as an embryologist, as a full-fledged embryologist. However, they have also said that those people who have been working already in the clinics can be absorbed, provided that they have this kind of an experience in embryology in an IVF clinic. So that is how. So therefore, if you have a senior embryologist who's been with you but is not a postgraduate, he will no longer be the chief. There will be another chief who has any of these qualifications, but this person can be allowed to still function with you. That is what is actually something that the Embryology Society is fighting against. Then coming to the definition of a counselor, anesthetist and director, there is really nothing much. Of course, that you must have a postgraduate or a graduate in psychology and clinical psychology for counseling. you must have of course, you will require an anesthetist who will be a postgraduate in anesthesia, and the director can be a postgraduate in either a medical science or life sciences or even in management sciences. So that is how the level 2 clinics are supposed to be functioning. Then came the mandatory equipment that was required, and in level 1 it was very basic. You have a centrifuge machine, a microscope and a refrigerator. However, in level 2 clinics it was slightly more advanced, and therefore, but of course, in the March 22 guideline, this level 2 clinic equipment was much more and much more sophisticated, as you would want in a high-end clinic or an absolutely state-of-the-art clinic. However, they probably felt that this was too much, and all over India, they probably could not expect people to have that kind of a clinic, that kind of a lab. Hence, it was reduced to this equipment, which is mentioned over here. So basically, this is a must. It must be there. Otherwise, you cannot start an IVF clinic or a center anywhere. And then about requirements of conduct of cycles. Now, this is very important for us clinicians. We must remember that there are specific types, specific ages, specific conditions wherein you can do self-cycles even, and I will come to the others. Age of the couple, for the female, she has to be between the age of 21 to 50, whereas in a male, 21 to 55 years. She has to be, they have to be legally married, or it can also be done on a single woman. But a single man or a same-sex people are not allowed ART now. Marriage proof is not mandatory in the Act, but some centers have opted for it to be safe. Like I remember that in Max, we were always taking this marriage proof earlier from every couple, because that was a mandate of Max Hospital. You have to get it done from a notary. It has to be a notarized proof that this couple is married. Only then you take them up for IVF. So a single man or a same-sex couples are not allowed IVF. Proper consents are important, proper data entry and storage of gametes and embryos for not more than 10 years. So mainly these two points are very, very important, the age and the marital status of the couple. Again, for donor cycles now, all donors, both male and females, must be recruited through a registered bank, even though they are known to the family. If they are known to the recruiting couple also, they have to come to you through a registered bank. Age of the recipient, again the same, male 21 to 50 and male 21 to 55. Age of the donor, female 23 to 35 and male 21 to 55. So here there is no difference, but here there is a drastic difference, and we know why, because of the ovarian reserve. So therefore 23 to 35 and here 21 to 50. I do not understand why this cannot be kept the same, but anyway, this is what it is. Sex and marital status of the recipient, again, married or single woman, one donor per couple once in a lifetime. That is what is the mandate now. Can be a known or unknown donor, but it has to be routed through the ART bank. Donor embryo, again, this is a query which many people are having at the moment. The Act is silent on this, but since both donor gametes are allowed legally, it is presumed that donor embryo is also permitted. You can probably take a donor egg and a donor sperm and then give them a donor embryo. For one donor sperm and one donor oocyte, and then you are safe and you can carry on. Then what are the certifications required? Insurance cover for at least a year, which should be covering the complications of OPU. As we all know, there is no such insurance at the moment. The only thing that has come out is certain group insurances, which Tata AIG or something, they have come out with one. And then there is another insurance company by the name Star Insurance. They have also come out with one. But these are group insurances which the banks have started to take on. And under that they are insuring the donors. The affidavit has to be signed by an executive magistrate or a notary, as against the judicial magistrate, which was a big pain, and everybody was finding a big problem in getting it done from the judicial magistrate. Now this has been actually, it has been rectified with a notification which came out on 10th of October, and it is this is now possible from there on, and you can get it signed by a notary also, and then that affidavit will work. So this is not required for a semen sample. This is another query that people have. Should we do this again, an insurance and an affidavit for semen? No, it is not required, because there is no life risk in giving a semen sample. There is no anesthesia over there. So therefore, this is not required for them. Proper consents and data entry in both clinic and bank is there. And of course, storage of gametes for not more than 10 years, again in donor cycles. A direct compensation is not to be given to the donors. They can be paid indirectly by the bank for transportation, loss of wages and works, but as such, no direct compensation to be given to the donor. And mind you, please remember, whenever you have to pay the donor, she should be paid through the bank. You are not to pay the donor yourself. There, nowhere in your own account should it be mentioned that this payment went to the donor, because basically why I'm saying this very directly is because recently lots of clinics were implicated in the GST for not paying GST in donor cycles, and that was a very big issue. So therefore, we remember now the donors are not our responsibility. The payment and anything to do with the donor is not our responsibility as far as finances are concerned. That should all go through the registered bank from where you have procured the donors. Now coming to the surrogacy now. Surrogacy, again, there is a change in the age again over here. Female should be 23 to 50. Male 26 to 55, and somehow they are saying that the patients should be married for some time before they can opt for a surrogate. The intending woman, that means intending woman or single woman, she should be in the age of 35 to 45 years. Again, this is interesting. She cannot be in this age. She has to be between 35 to 45 years. She should be either a married, divorced woman or a widowed. Single woman who is not married is not allowed to do surrogacy. She has to be either divorced or she has to be a widow. The surrogate's age should be between 25 and 35 years. That is the difference in the age groups of these different people whom we are going to be using now. So now the most important thing is the consent forms for ART. Now we have forms from the Act. We have forms from ICMR guidelines, and we have forms from PCPNDT. So therefore, now there is a huge jumble of these consent forms which we have to sign in order to fulfill what is written in the Act, because the forms that are given in the Act are not complete. There are so many forms which are missing. For instance, the form for the embryo transfer even is missing in the Act, the forms that are given for the Act. Whereas in the ICMR guidelines, the forms were much more comprehensive. So then, of course, we are very familiar with the PCPND Act. So this is, if you can please take this photo, because this we have actually formed this. This is something which my colleague, my senior consultant, Dr. Vandana, has actually formed this for us, so that we don't forget any of the forms that we are supposed to fill. This is in cycles, any IVF cycles. So these are the forms from the ART Act, and these are the previous forms that we were supposed to fill. So therefore, you must remember that you have to fill up all this when you are doing any kind of cycle, for instance, for any kind of procedure that is going to be done for ART. And if you look at the summary of this summary, this is quite comprehensive and complete. It doesn't have surrogacy, but it has everything else. Self cycles, you have to fill up these forms. IVF with donor oocyte, you have to fill up these. IVF with donor sperm, these forms, and so on and so forth. So remember, the forms which are given in alphabets are some of the old forms and the PCPNDT forms, and the ones that are given in numbers are basically, for instance, form 12 and 6. These are the ones which are given in the Act. So just keep this in mind, and you have to keep on forming these bundles when you are doing these ART cycles. Another important thing that has come up in this ART Act is the grievance redressal. Every clinic must have a grievance cell with respect to the matters which are relating to the clinics, and the manner of making a complaint before the grievance cell has been specified in Form 5. However, the manner of forming this cell is not written anywhere. We do not know who are going to be the constituents, who are the people who are going to be participating in this grievance redressal function, and who are the ones who are going to be responsible for this. So that definitely needs to be clarified. And the downside of this cell is also that anybody can come and say that, I have not been able to conceive and so I want my money back. So things like that will come up, and therefore this is something which is going to be quite a pain in our neck when we do the ARTs according to what is written in the law now. This I have partly mentioned, storage, renewal, consent or destruction. Remember that the sale and transfer of gametes is not allowed, as it was not allowed earlier also. But of course, what is important is that outside of India is completely prohibited, except in the case of transfer of own gametes or embryos for personal use, and that also with the permission of the National Board. And like I said, the perishing of the embryos or to destroy the embryos also, there is a method now given in the Act which you can follow, but of course a prior consent is definitely always important. So to summarize this whole thing, registration of clinics and banks, meet the mandatory requirements of the staff, equipment and data, and selection of both self-cycles and donors according to the law. So this is in summary what is the Act and what we are supposed to be doing, and of course lots of paperwork and data entry so that we can do justification to whatever work we are doing. And now we come to the bone of contention, the Surrogacy Act. The Surrogacy Act has also been the surrogacy was legalized since 2002, and of course it has gone into disrepute over the years, because of this problem of renting a womb, we were disgraced all across the world. But yes, most importantly was at the turn of the century, the social surrogacy for convenience is what has actually led to the problem of what we are facing today. And that is because basically we do not, this particular treatment needs to be given to only people who need it and not as such for everyone. So basically, initially they came out with the surrogacy bill, and then it was decided that this is a part of the ART. Hence, it was not passed in the Parliament earlier, and later on in December 2021, and then in January 2022, both the acts were notified at the same time, and hence, therefore, we have the ART and surrogacy bills coming up together now. So the highlight of this bill is a ban on the commercial surrogacy, and altruistic surrogacy is now the only type allowed. However, there is a lot of criticism about this because we all know that this is not going to curb the exploitation. On the contrary, it may increase the exploitation because now commercial surrogacy will continue to happen, but it will go into the grey market. What then are the pros and cons of altruistic surrogacy? The pros is supposed to be a decreased cost, familiarity with the surrogate, and an accessibility of the surrogate. These are supposed to be the pros of this kind of a situation. However, the cons are strained relationships between the surrogate and the couple, the commissioning couple, the less safeguards and costs. Now, for instance, in a family, there may be a sister-in-law or a daughter-in-law who is forced to do surrogacy for another person in the family because the family is so demanding and so aggressive. They do not let her do what she wants, and such things can happen. There will still be exploitation, and there is a possibility that women will still be forced to go in for treatments like surrogacy for relatives of theirs. So that is the downside of altruistic surrogacy. However, time will tell us what side we are going to go. But now then the requirements are really very daunting. Heterosexual couple married 5 years. Remember, they want that there should be some kind of a marriage over there established before they can go in for surrogacy. Man between 26 to 55 and female 25 to 50. A certificate of essentiality is something which is a new thing which has come out, and this has to be taken from the authority, from the local authority. Certificate of essentiality means that this patient is actually requiring surrogacy and that it is an essential treatment for this patient. Therefore, it requires this kind of a certificate. Should have had no other biological, adopted or surrogate children, and basically then only they are eligible. not for commercial purposes, not for producing children for sale, etc. For any condition or disease only specified through the regulations. For couples who possess a certificate of essentiality, surrogate to be known to the couple between 25 and 35 years of age, agreeing to do the procedure altruistically, and the surrogate again must have a fitness certificate from the authority. So first of all, an essentiality certificate, then a fitness certificate of the surrogate from the authority. These are the two mandatory certificates, and in addition to that, there is some more. So permissions that are required from the board are for the recipient couple, an essentiality certificate and an eligibility certificate, and a certificate of belonging of newborn to be born to the surrogate. So this is something which is new. Till now, we were sending the birth certificates to the NDMC or to the municipal corporations to get a certificate made for that couple. And now, even before the whole cycle is begun, you will get a certificate. The commissioning couple will get a certificate saying that this particular surrogate that they have chosen is going to give birth to a child which is deemed to be their child, and it will belong to this couple and not to anyone else. So this kind of a certificate will be issued by the board even before the surrogate cycle is started. Donor, on the other hand, needs what I mean is a surrogate means medical fitness and an affidavit of willingness for altruistic surrogacy. These two are important as far as the surrogate is concerned. What are the offences? Sex selection is something that we all know, and a huge fine, and of course 10 lakhs, and it may extend even to 25 lakhs of rupees, with of course an imprisonment also, which is not going to be less than 5 years, but can also extend to 10 years. Again, there are others, similar things that we have talked about earlier. No import of embryos, no selling of embryos, no abandoning of or disowning children. So all these things basically which we know are, there is nothing which is new in this, except that the punishment is basically 5 to 10 lakhs, and the term is not less than 3 years, but it may extend to 8 years with a fine which could be less than 10 lakh rupees, but may extend even to 20 lakh rupees. So huge fine and a huge imprisonment punishment. That is why any of these offences are all listed down in the law. And again, for surrogacy, the jail term of 10 years and a 10 lakh rupee fine is there, as against the other forms of ART. So this is a larger punishment, and therefore a much more stringent punishment in this case. And we all know that these are the things which we should not be doing in a case of a surrogate cycle, which is not something new, which was existing earlier as well. Now, this is the good point of this whole act. This is something in our favor. Please read this chapter in great detail, this chapter 7, which everybody thinks is miscellaneous and should not be read. But this is the chapter which allows us, gives us the power to remove difficulties or ambiguities that we have in this whole issue. So if you have any difficulty, it can be actually, you can talk about it or send some kind of a complaint to the authorities. They will look into it and they will take proper action. If that is rectified, it has to go through the parliament, become a kind of a notification, and then only it can be, then it will come into force. And the only thing is that any such thing has to be done within a period of 3 years from the date of commencement of this act. So therefore, now we are nearly 1 year from the commencement of the act, and whatever we have to do has to be done within the first 3 years. If we go by the proper way, there is a possibility that the government may listen to us and remove the problems or difficulties that we are facing with this act. The same thing also is present in the miscellaneous chapter 8 of the Surrogacy Act. And here again, there are lots and lots of points. The main thing about, or the crux of this whole thing, is that if there is any difficulty arising, then the Act gives you the provision that the central government may, by order published in an official gazette, make such provisions not inconsistent with the provisions in the said Act to be appear necessary and expedite the removal of the difficulty. So therefore, this has to be done within 2 years. The earlier one had to be done within 3 years. Please remember, whatever problems we have to really act fast and get it done. So now, coming to a bit of philosophical thinking, Will this act really help us to regain the lost confidence amongst patients? Will you adopt remedial measures? Will you become more transparent, and will you become more honest? Is this act going to help us to do all this so that the patients feel better and more comfortable with us, or are we still going to be as lost as we were all these years and try and just go on doing whatever we can without really making any difference into the patient? So then, what defines success in IVF? Is it just the results? Or is it the patient satisfaction? Is it the patient retention? Is it the patient recommendation and referral, ethics and transparent practice, and reputation of being a good, honest practice? Is it this that actually defines you as a good specialist, or is it just the results that you have? So basically, yes, if a doctor remembers ethical, moral, and legal practices while treating both the couples and surrogates, there will be no conflict and there will be no punishment. So what should we do? We have to flow with the water. We have to comply with the rules, and we should not try to be flexible under any circumstances. We as doctors feel very sorry for our patients, and so many times we say, "Acha chalo, ye kar dete, let us do this." Please do not try to do any such thing for any patient, because you may land yourself into a problem with this very strict law now that has come in. And we all know that we have faced a lot of music with the PCPNDT Act already. We do not want to get into more problems. So therefore, try to be as good and as within the rules as you can. Do not be flexible so that you don't get yourself into trouble. Thank you so much for being here with me today. Thank you so much.
Thank you, ma'am. Thank you for